introduction. For anybody who's not met me before, my name's Cheryl. I'm the Society Matron for Benenden, which probably means in theory I give all their clinical consultancy. I provide help and support for not only our members but our product department, for our hospitals, etc. And I help with that. My background is that I'm a nurse consultant by background. And I was based in general practice prior to here. So I would see and treat anything that you would naturally go and see your GP with. I've also done procurement of services, commissioning of services, service transformation, all the usual buzzwords that you expect to see through the NHS and private health sector. I've done those. And then the other thing that I am is I'm a social scientist. And if anybody's met me before, you'll know that that's my academic way of saying that I'm nosy. I love to understand what makes people tick and why we make and choose some of the decisions that we do. And today's session is all going to cover the menopause. So by all means, if you've any comments or any questions, pop those in the chat box. We can have a look at those, and any questions I'll try and pick up either as we go along or at the end. But also, if you've any questions about the Benenden Health product, I'll ask Mark to put his email address in the chat box, or any questions about the menopause that you wouldn't want popping in an open forum, message them to Mark, email them to Mark, and he'll pass them on. And it usually takes me about 24 to 48 hours to answer those. So here we go, guys. Let's go for it.
Cheryl, just to if I request control, I can do the slides if that helps.
It's totally up to you. I'm quite easy either way.
It's up to you.
I'll continue sharing if that's all right, and then you can keep an eye on the chat box. Is that okay?
Perfect.
Brilliant, brilliant. So when we're looking at the menopause, we know that the British Menopause Society tells us that 45% of ladies feel that their menopause symptoms have had a negative impact on work. 47% of ladies have needed to take a day off work, and 25% of us have considered quitting work because of their menopause symptoms, which is just absolutely astronomical. And what we've got to bear in mind is every lady's journey is her own journey. So anybody born as a female has those genetic inherent hormones and is going to go through the menopause. We know that my journey may not be another lady's journey, which may not be another lady's journey. So there is a lot of variability in those symptoms and also in how we view and manage those symptoms. But I think part and parcel of the challenge that we've got is that we don't talk about it. That's the top and bottom of it. It's a little bit like the same stigma that we had with mental health many years ago, where people really wouldn't disclose their mental well-being. We're exactly the same about menopause. Not many people talk about it. And I think the issue for that is because of the way it's generically viewed within society. And if we think about some of the terms that we use when we talk about menopauses, ladies will chat that they're going through the change. What are we changing into, ladies? You know, I've not seen anybody change into a werewolf because they're going through the menopause, or change into something totally different. We're going through a change, or we're a little bit strange, or we're at that time in our lives. And they're all quite derogatory statements that we use. And when you look at sort of like comedy figures and things like that, they always portray this older lady with the curlers in who's quite buxom and butches her boobs up and talks about hot flushes. That's not always the menopause for a lot of people. So I think what we've got to do is we've got to appreciate that this is an individual journey and it's a natural transitional journey that we're going through, because that's what's happening. The body is naturally transitioning into its next phase. About 80% of ladies going through the menopause will experience symptoms, and around a quarter of those will have some severe symptoms. So we're going to have a look and a little bit of a chat about some of those as we go on. But first of all, we're saying this word menopause, we're talking about it, but what does it actually mean? So a natural menopause happens very roughly between the ages of 45 to 55, but the average age is 51. 3 in every 4 ladies will experience symptoms, and we know that 1 in 4 will define those symptoms as severe. And we've already said that it's everybody's journey. Each person has their own particular journey with this. So be guided by your own experience and own journey. It is a natural process. It's a natural transitional process. And that natural transition is when your periods are starting to drop and go because you're losing ovarian function. So it's your estrogen that's declining and dropping. What we find is when we hit puberty, we get this rush of hormones coming through with puberty, and that's why puberty can be a bit grotty, not only for the person going through it, but for the people around it, because their hormones are all over the place at 6s and 7s and really difficult to manage. And that's a little bit like menopause. It's going through puberty in reverse. So what we find is a natural pubertal young lady will find that she's got 4 main hormones driving her period cycle, and there'll be her luteinizing hormone and a follicle stimulating hormone. And what they're doing is they're helping to maturate the egg within the ovary, and they're helping the ovary to produce and release that egg. And then what's the other hormones that she's got is estrogen and progesterone, and they're helping to support the womb lining, helping to support that egg through fertilization or through the shedding of the womb lining. And they go through this cyclical process that happens. Now, as we start hitting the menopause, what we find is we go through a phase called the perimenopause. So this is as we're just starting with our symptoms. And there's a lot of research out there that tells us that this can be the most symptomatic phase for ladies. So your perimenopause, I would love to say to you, it's 1 or 2 years and it'll be done and dusted. But remember, it's each and everyone's journey. So we're all very, very different. It can last for 5 to 10 years. It can last for 5 to 10 weeks, you know. We're so different, but it is classed as the most symptomatic phase. And the types of symptoms that you might get are those hot flushes, night sweats, changes in your menstrual cycle, vaginal issues, breast tenderness, skin and hair issues, altered sleep, mood swings, sexual desire changes, tiredness, joint aches. The list goes on and on. And the reason that we get these is because of that ovarian failure. The estrogen's dropping and the ovaries are becoming less efficient at releasing that last supply of eggs. So we're definitely going to go through the symptoms and have a chat about some coping mechanisms for them. But that perimenopause time can happen at any point. Now, if you're a young lady, so if you're in your early 40s and you're going through the perimenopause, so if you have those symptoms, it's really important that you maybe go and have a chat with a clinician about those. And the reason for that is if you're going to go through your menopause a little bit earlier, it's very, very worthwhile considering some HRT at an early stage to protect not only your bone health, but your cardiovascular health. The other things to think about if you're going through it earlier is that if you're still wanting to plan a family, you're in your early 40s, you're still wanting bambinos, your egg function is declining, so your fertility is dramatically declining. So again, that's something that's worthwhile thinking about, seeing a clinician sooner rather than later for that. Now, your menopause is in that last 12 months of having periods, whether they've been regular or irregular, lighter or heavier. That's when you're menopausal. And then postmenopausally is when you've gone 12 months without any periods. You may still have some of those usual signs and symptoms, so some of the hot flushes, etc., but they should be starting to wane, and you should go 12 months without a period. If you have gone 12 months without a period and then you start bleeding again, it's one of these things that I definitely ask you to go and see your clinician about. A postmenopausal bleed definitely needs a little bit of a discussion with your clinicians over. So let's have a think and a little bit of a chat about some of those most common signs and symptoms that we get. So we've got there some of the really common ones, and I'm going to break them down and go through and some of the management strategies within them. but that's not an exhaustive list. We know that ladies are affected with far more than what's on there. You know, so if you are struggling with something that's on there, or it's something that I don't cover, please, please, please do by all means ask the question, send the email. Let's see how we can support. Now, the next section, we're going to discuss a lot of those signs and symptoms, and what you might find is that there's some anatomical descriptions in there, there's some clinical terms in there, and it's definitely not said to cause offence to anybody, but you know, not mentioning what goes on below the belt is a little bit like talking about fast food and not mentioning McDonald's. You can't do it, it doesn't work. So we need to be open and honest about some of those conversations. So the first one that we're going to have a look at is our vasomotor symptoms. So this is just a clinical term that we use for our hot flushes and our night sweats. Now, hot flushes and night sweats, they're one of the hallmark symptoms. It's quite often one of the first physical manifestations that we get that our ovaries are starting to decline in their function. So they're not working as well. You might find that you get these occasional, I call them personal tropical moments, quite a while before you get any period changes, you know, so before you actually feel those period type happenings or that menopausal movement. And it is the most common symptom. A lot of ladies describe it as this sort of like heat, this rising heat sensation, as though it hits from the feet and it literally waves over the body, and they feel as though they're burning up inside, as though there's a massive intensity. To actually physically look at a lady with a hot flush, what you might see is you might see somebody a little bit red and sweaty, but usually what you do see is somebody giving it this with a lot of papers, wafting or trying to get near an open window or a fan and looking a little bit hot and bothered. We know that about 60 to 85% of ladies have a variation in the severity and the duration, and about 20% say that the hot flushes are that severe that it's affecting their personal and their professional lives. Generally, but it is a general, they tend to last for about 2 years, but a hot flush itself, when it happens, usually lasts for about 5 minutes. And physiologically, what happens is we've got a thermoregulation part in the brain, so it controls body temperature. And that thermoregulation gets this signal that the body is overheating. Okay, so what it tries to do is it tries to decrease the heat within the body. And how it does that is it opens up all the blood vessels, so it vasodilates, so all the blood vessels are through the body open up, which gives you this bit of a flushed appearance because the blood is coming up to the skin. And then what it also does is it opens up the sweat glands to try and cool the body down, and that usually helps then to bring the body back down. There is certain things that can make your hot flushes worse. So if you've got more jiggle in your wiggle, your hot flushes will be worse. So what I mean by that is if you're carrying more weight. So if you're overweight or obese, your hot flushes will be worse. So it's definitely worthwhile controlling that jiggle in your wiggle. Alcohol definitely makes your hot flushes worse. We know this from evidence. Excess caffeine, so caffeinated teas, coffees, hot chocolates, certain foods that have caffeine in them, fizzy drinks, stimulant drinks are all going to make your hot flushes a little bit worse. Spicy food, again, it's playing with the thermoregulation centre in your brain and can definitely increase those. So how do we manage them? What do we do? So the first things that we can do from a personal point of view is do what I call dress like an onion. And what I mean by that is by putting layers on. So rather than just having a dress on or a blouse and a jacket on, maybe layer the clothes up and go with natural fibres. So I'd be looking at maybe a cotton camisole, a silk blouse, a wool jumper, that type of thing, because it's easier to take a layer off than it is, you know what I mean, if you're feeling hot and sweaty, than if you've just got one thick layer on. So it's easier to do that, and natural fibres are renowned for breathing much easier than synthetic fibres. By the same token, definitely think about on a night time for those night sweats. And what I would suggest there is, rather than putting your winter weight duvet on, put 2 summer weight duvets on, so you're not playing duvet disco. You can literally take 1 layer off rather than needing to flip it all off, getting really cold, putting it back on and playing duvet disco. Other things that we can do on a nighttime point of view, well, at any time point of view, is CBT is really, really good. So CBT stands for Cognitive Behavioural Therapy, and there is an evidence base that using CBT can help support your hot flushes. It can help for the body to manage them, and how you can psychologically manage them. So if you're a member of Benenden, obviously CBT is available through Vita, and that can help. There is a good evidence base. Pharmacologically, so medicine wise, there is certain mood medications that can help with hot flushes. So they're antidepressant type medications. There's also an antihypertensive, a blood pressure medication that can help with hot flushes. And obviously neither of those are hormone in origin. But the gold standard really is your HRT. You're having your hot flushes because your body's losing estrogen, and because the body's losing estrogen, if we replace that hormone deficiency, you'll find that the hot flushes settle off a little bit. So this is where we start going through the below the belt kind of symptoms, and the primary one that I used to see in general practice was ladies who were struggling with their periods. And let's face it, ladies, a large part of our life is tied up with our periods, and we all have very different intensity of periods, very different nature of periods, that type of thing. But it's when it's causing you issues with your professional and your personal lives that you need to do something about it. The vast majority that we would see was because they were having very heavy periods or very painful periods. That would be the vast majority. I must admit, I never ever got a lady through who came to me and said, "Oh, it's fabulous, my periods are really light, doctor, what do I do now?" I never got any of that. It was always the ladies that were really struggling with that, that made it difficult. Theoretically, heavy menstrual bleeding is classed as an average blood loss of over 80 mils. But you know, don't be worried about having to measure how much blood loss you've got. If you're having to change your sanitary wear regularly, or if you're bleeding through your sanitary wear or losing clots, then it's definitely something to come and see a clinician about. And the reason for that is it's a little bit like when we talked about puberty in reverse. The hormones are all over the place. The body's not quite sure what it should be doing, so it goes into overdrive a little bit. There can also be some other reasons as well why it can happen, from an anatomy point of view. You know, if you've got fibroids, etc., it can cause issues. What do we do about them? So my first and foremost thing is, don't please sit and suffer in silence about them. There is loads of things out there that can help to make it easier. Definitely within Benenden product, we can help to diagnose why you might be having heavy menstrual bleeding, and we've got certain procedures that can help with it as well. But for you as ladies, definitely make sure that you're eating well, because the last thing you want to do is to become anemic. So you need to make sure you're getting plenty of iron in your diet. And then the other thing to think about is how you can manage it, if you would like to do so, by medication. The vast majority of medications that are out there are those that we use from a hormone point of view. So it might be a progesterone only pill. It might be something to help with the pain. The other option is, and it's the gold standard, this is the thing that makes such a difference to so many ladies, is called a Mirena coil. Now, I know a lot of ladies, as soon as you say coil, will cross their legs together and wince a little bit. But the Mirena coil is a phenomenal bit of kit for any lady. What it does is it sits just in the neck of the uterus, and it releases a small amount of progesterone. And what we find is that small amount of progesterone that's delivered locally within the uterus means that for a lot of ladies, they either have no periods or very light periods. But it helps with other things too, and this is why I love it. I'm a Yorkshire woman and I love a bargain, and that's what the Mirena coil gives us. Number one, definitely gives us period control. phenomenal, absolutely brilliant. The second thing that it does is it provides us with contraception. So if you're still bleeding, you're still fertile. So you need to think about your contraceptive cover, and HRT is not contraception. So you need to have some form of contraceptive cover if you're sexually active. So that's the second thing that it does. And then the third thing that it does is for a lot of ladies who are using HRT, if they still have their womb, their uterus, they need to have two types of hormone, progesterone and estrogen within their HRT. And the Mirena coil provides the progestogenic component of it. So it saves you a prescription fee every month. Bonus, it saves you money, it gives you contraception, and it calms your periods down. You know, I could do with shares in it. I love Mirena coils. They give ladies such a great quality of life. So that's a consideration for anybody who's struggling with their bleeding. If it is something that you're interested in, have a chat with your clinicians about it. It may be the right thing for you. It may be something just to consider. So the other thing that we find as well is we get lots of below the belt vaginal symptoms. Sorry, ladies, excuse me. Sorry, quick. And if anybody's not gathered, I do chat quite a bit, so I need to drink regularly. So sorry. So those vaginal symptoms that we get, the reason that we get them is estrogen is like our Estee Lauder for our nether regions. Estrogen provides us with the lubrication and the moisture to all those anatomical areas there. So your vagina, your cervix, your endocervix, your endometrium, your myometrium, everything is fed by estrogen. It gives it that wonderful plumpness and moisture within the skin. Now, if you imagine taking that moisture away, imagine having very, very dry skin, very dry hands, and it feels dry and itchy and awful, and you just want to be scratching it all the time. That's what some ladies will experience below the belt. That's what they'll experience within the genitals. So the genitals can feel uncomfortable, they can feel painful, they can feel itchy. When they have intercourse, it can be painful, and that's that dyspareunia. It's painful intercourse. And we know that it can be a real difficult personal thing for a lot of ladies to manage. The answer to that is, what would you do if you had dry skin all over your body? You'd be putting moisturiser on, and that's exactly the same analogy that we'd need you to do within your genitals. Now, it's not about getting your pot of Estee Lauder and putting that down there. That's not going to do the job. There is special moisturisers that work within the vaginal area. There's two that you can buy over the counter. So there's one called Silk, and that's SYLK. Absolutely fabulous. A second one's called Replens, REPLENS, and again, both of those moisturize the area. They penetrate through the tissues to give you some moisture there. Once a day, you know, morning or evening, just to help. You can get hormonal variations, but you'd need those on prescription. Now, a lot of ladies will say to me, well, I use KY jelly. Is that not the same? And it isn't. What KY jelly does is it provides sort of like a slippery surface. It lubricates. So it's absolutely fine if you're having personal time with your partner or personal time with yourself, but it won't moisturize the area. It literally sits on the skin surface, and the Silk and Replens will help to go below that skin surface. The other things that we find is that can generally increase as we get a little bit older is we get a lack of libido, etc., and that can make a bit of a difference for some ladies and some with their partners. There is some areas in the UK that will prescribe testosterone, so it's an androgenic hormone, a male hormone is testosterone, but it can definitely make a difference to sex drive. But it depends upon whether your clinicians are comfortable prescribing that or not. But it's a discussion point with them. And then the other thing to think about, because we're drier down there, we're more at risk of infections, and that could be thrush, that could be waterworks infections, that could be sexually transmitted infections. So definitely, you know, make sure that if you've got new partners, changes of partners, that type of thing, make sure you're using a barrier method of contraception, and if you are struggling with frequent waterworks or thrush type infections, make sure that you're seeing your GPs and using that moisturiser to help protect the tissues there. Now, this is where I get on my soapbox, so apologies, you're going to have to tell me to get off my soapbox about this, but urinary symptoms, I think, have been not discussed, not made apparent, and people are trying to normalise them, and it's wrong. The adverts will tell us that an oops moment is absolutely fine, and how we manage an oops moment is we put some sexy incontinence wear on and nobody will know any different. But I would challenge any lady who is struggling with an oops moment not to feel uncomfortable about it. Incontinence wear can help, but it does not resolve the problem, and nobody, I mean nobody, has to put up with an oops moment. So please, ladies, if you are struggling with oops moments, come and see one of us, come and have some chats. Let's see what we can do to help. So oops moments tend to come in a couple of, well, they tend to cover 3 different categories, but the 2 main ones are stress incontinence. So this is where you cough, you laugh, you jump, you sneeze, and you leak a little bit of urine. Or you get urge incontinence, and the easiest way I can describe urge incontinence is you're driving home from work, you get halfway home and you need the loo, so you're patting your legs in the car or the bus, you're doing all you can to hold it, you actually get home, you run up to the door, you're looking for your car keys, you're still jumping about and patting your legs. By the time you've got house keys in the door, you've dribbled a little bit of urine, so you've not been able to hold that urinary flow until you've got to the loo. So it's that small amount of dribbling of urine that they class as an oops moment. The vast majority of reasons that we get them is that our pelvic floor, so that's like a sheath of muscle that sits within our pelvis that holds up all our pelvic organs, isn't working fabulously. It's got a weakness in. So the first and foremost thing that we need to do is our pelvic floor exercises. So this is something we can do for ourselves. So what I would say first and foremost, and you know, we can all sit and do it together because nobody will know, is imagine that you've got a lift. Okay, so imagine you sat on the loo and you're going to have a wee, but you're going to stop yourself from weeing, and you're going to clench all those muscles down within your pelvis, so you'll feel it within your vagina, you might feel it a little bit in your bottom, and you're going to hold it, and then you're going to clench them a little bit tighter and hold it again. And then you're going to clench them a little bit tighter and hold it again. And then you're gradually going to let the muscles relax a little bit. And all that you're doing there is you're doing squats for your pelvic floor. You know, you're doing bicep curls on your pelvic floor. We're working that muscle, and that's what we've got to do. It's really important to work that muscle. And by doing that, you'll about 50% of those ladies who are struggling with oops moments will find that their symptoms either totally disappear or get much better. Now, your pelvic floor exercises, I would definitely say join them with another activity. So every time you wash the pots, do your pelvic floor, or every time you brush your teeth, or every time you boil your kettle, because if you stack habits together, it's much, much easier to remember to do them. The next things that can be done is there's definitely different medications that are out there that can help support that. So definitely you need to have a chat with your clinicians. But then thirdly, there's also surgical interventions that you can have to help if you've gone through the others and they've not worked. And if you're Benenden members, definitely we can help and support that. That's not an issue at all. So we've got to remember 1 in 3 of us will experience bladder symptoms at some point. Yeah, so over 1/3 of us will experience this at some point, but only 20% will actually seek help for it. So don't be part of that 80% that's living with an oops moment. Incontinence wear, no matter what they tell you, is not sexy and it's not required for the rest of your life. Please start doing your bicep, your curls on your pelvic floor, and come and have a chat with one of us.
Cheryl, we've just got a hands up.
Yep.
Brenda, is that you with your hand up? Brenda O'Boyle? Maybe not. Maybe not. Don't worry. We have got a couple of questions as well, Cheryl, which I said we'll pick up at the end of the session as well. So we'll
Brilliant. Are you keeping a track of those for me? Because I'm on a roll and I'm gassing away 10 to the dozen. Is that all right?
Yeah, that's fine. Yeah.
Thank you. Brilliant. So let's have a look. We're on to sleep next. So from a sleep point of view, sleep is one of these things that we all absolutely love. But it's one of those elusive things for some of us that we would definitely aspire to, but we don't always get. And with sleep, we need a good quality of sleep as well as the right quantity of sleep. So it's all right having a full night's sleep, but if you're asleep, awake, the quality of it isn't very good, because we need to have both REM sleep and non-REM sleep to make it a good quality. Now, what happens when we're going through the menopause is, because of that ovarian deficiency, you get a decline in estrogen. We've already established that one. But what that does is it induces a change in your sleep cycle. So restful sleep becomes much more difficult, and for some, nigh on impossible. But also that latent phase of sleep, so that time that it takes us to drop off to sleep, is actually shortened. Is lengthened. So dropping off to sleep takes much longer, so our good quality sleep is shortened. So what we find is that it takes us longer to get to sleep, and whilst we stay asleep, we definitely aren't able to maintain that good quality of sleep. Now, when you add that onto things like night sweats, they disturb your sleep. If you think about the point of life that we're at, when we have lots of professional pulls on our time, lots of personal pulls on our time, we might be getting kids to uni or getting kids back from uni. We might be looking after elderly parents. We might be juggling outside interests other than work and life and home. We might actually be trying to fit a bit of something in there for ourselves. Our stressors definitely affect it as well. So we've not only got this hormonal imbalance that's affecting our sleep, but we've also got this natural life cycle balance that's affecting our sleep, those natural stressors that happen. So sleep-wise, there is no magic answer. There is no one pill fits everything for sleep. What we find is quite often the very best thing that we can do for ourselves is something called sleep hygiene. And what sleep hygiene is, it's just a set of habits. There's about 10, 12 habits on there. And remember what I said about habit stacking? It works much better if we combine it with something. But because it's a habit, what we find is it doesn't work immediately. It takes us a little bit of time to get the body into sync and working well. So you've got to retry it and retry it. So it's really important that you keep going with those habits, and that will definitely help. The other thing to think about is we've already chatted how that drop in estrogen can definitely affect our sleep cycle. So by replacing that estrogen can, for some ladies, help to restore that sleep pattern. So definitely having to think about HRT, which is a way of restoring our estrogen level, definitely helps and makes a difference there. So, you know, if you're really struggling with your sleep, and let's face it, sleep deprivation affects everything in life. Nothing works well if we've no sleep. It's definitely worth having those conversations. So I put mood disorders on there, and that little cross face definitely is some of us at some points in the day. Nobody is Mary Poppins all the time. You know, we all have times when we naturally feel as though we're a bit of a grumbly bum. Definitely struggles, you know, but that's normal, that's natural. But actually, if our mood is affecting us more commonly or more often, you know what I mean, than is the balance, then we need to have a think about it. What we find with hormones, with our menopause, is that fluctuating hormones has a dramatic effect. So imagine the moody teenager. We've gone from being a moody teenager to a moody lady of a certain age. Yep, it's normal, it's natural, it happens. And some of us can shrug it off and phase through it. Some of us it really affects. There's a clinical term that we use, and it's called volatility of effect. And what we mean by that is when ladies are adversely affected with their hormones, what we find is that they might be unduly depressed or unduly low mood much more than they usually are. They might cry at absolutely nothing that before that wouldn't have bothered them before. They may feel really apathetic. They just cannot be bothered with anything. It's that feeling about things, and they're all can be normal menopausal type things. Now, counselling and emotional support are absolutely brilliant. They do help and support in a lot of ways, definitely. HRT, again, this is happening because of that hormone fluctuation. If you're replacing the hormones, it can help and support. So that can definitely make a difference. But what I would say is, you know, if you are struggling with your mood, definitely go and see one of the clinicians at your GPs, because it's really important. You know, life's too short to be unhappy day in, day out. Let's do what we can to help and support that. Definitely, if it's counselling that you might need, that might help and support if it's a bit of CBT. And again, through your GPs or through your Vita product through Benenden, or using the Wellbeing app. There's lots of things on there. So download your Benenden app and have a look on there. There's lots of things that can help and support. So if you are struggling with mood, it's definitely worthwhile having some of those conversations. Right, I'm going to have another drink of tea again. So sorry, ladies. Brilliant, thank you. So the next couple of slides I put on there are things that happen that increase in nature once we've gone through the menopause. So one of the things that does have a big impact is our bone health. So our bone health will naturally start declining as we get a little bit older anyway, male and female. But for women, whilst ever we've got a good amount of estrogen there, our bone health is a little bit more productive than our male counterparts. Obviously, we lose that estrogen and our bone health dips, and we are more at risk of osteoporosis. And what that means is that the mineralization of the bones, the strength and the density of the bones isn't there. We start to lose that mineralization. So what we know is that it is a natural consequence of aging, but it's increased in the menopause. Things that might make it worse. So there's certain things that we can't change. Our age, as we get older, we have this bone demineralization. We can't change our age. We can't change our gender from an anatomical point of view, from a genetic point of view. So if you're born as a woman, you're more at risk of osteoporosis. We can't change that. We can't change our family history. So if you've got a parental history of fragility fractures, again, it increases your risk more. But what we can change is our lifestyle. So smoking is a very definite red flag risk area. So cut out the ciggies, stop smoking, that will help your bones. Not jiggling your wiggle, so not exercising, is horrendous for bone health. It's really important that you exercise regularly, and it's the type of exercise that you do. It has to be weight bearing. Now, what I mean by weight bearing exercise, I am not expecting anybody to go powerlifting at the gym or do CrossFit or go running unless you already do that and you love it, or you want to take up a new sport or hobby. Exercise, weight bearing exercise could be something as simple as dancing around the kitchen, going gardening, going for a brisk walk outside. It's about moving the body so that it's putting a little bit of impact on those joints. Doesn't have to be high impact. It doesn't have to be running or jogging if your knees and hips don't manage that, but definitely it's about using that about that impact exercise. Look at your diet. If you've got a beige and boring diet, how on earth is your body going to give it the right type of vitamins and minerals it needs? It needs a good amount of calcium. It needs vitamin D, amongst a raft of other things to help support our bone health. So definitely, I call it eat the rainbow. Have a look at the rainbow of food on your plate. If you've got a rainbow of colour on there, absolutely fabulous. That probably denotes you've got lots and lots of different vitamins and minerals. If you've served up a pizza or chicken goujons and potatoes with no veg, it's beige. You've not got much variety in there. It's about getting those things in there. If you're snackish, snack on sugar snap peas, baby sweet corn, almonds. All of these things are definitely improving, you know what I mean, that nutrient content. And the other thing to consider is your weight. Again, if you've got more jiggle in your wiggle, you are definitely increasing your risk of osteoporosis because you're putting excess stress on your bones and joints. So think about your weight. Let's have a look. So cardiovascular disease, again, one of these things that increases once we've gone through the menopause. Our estrogen, our lack of estrogen stops that protective factor that we had before. And again, we have very certain modifiable and non-modifiable factors that we can do to help protect our heart health. So things that we can't change, our gender, our age, our ethnicity and our genes, we can't change those, and they're definite risk factors for cardiovascular disease. But again, you could probably answer this for me. We can change our lifestyle. We can look at our smoking, our drinking, our eating, our exercise, and we can help to work with those to help support those. Nearly there, ladies. I hope you're all sticking with me. So I've just called this slide out as things that I wanted people just to be really aware of. I've already mentioned, but I am just going to go back over it. Things that I would definitely be wanting you to go and see your GP with that are really important. If you've gone 12 months without a period and then you start to bleed again, you need to go and see one of your clinicians. Now, it could be something and nothing. It could be a little bit of trauma from intercourse. It could be a little bit of infection, but you need to go see somebody to make sure that it's not a true red flag postmenopausal bleed. By the same token, if you've got bloating within your abdomen, if you've got pain within your pelvis, so those lower abdominal organs, and your urinary function, you're needing to go urgently, you need to nip and see one of your GPs about that, or one of the clinicians in your general practice surgery. 9 times out of 10, it could be a bit of a water infection, it could be a bit of IBS, it could be something of that nature. But again, don't ignore it. Definitely have a chat with somebody so that they can get that checked. Screening programs, our boobs, ladies, our boobs are so important. We all have breast tissue. Male and female has breast tissue. By nature of our anatomy, born as female, you generally have more breast tissue than our male counterparts, but both sexes should be checking their boobs for lumps, bumps or changes. So when you're checking your boobs, first and foremost, what I would say to you is get used to what they look like normally for you, because it's any change in the normal is the thing that you're actually going to be calling out and asking for somebody else to check. So stand in front of a mirror and have a look at your boobs, and do they look as they've always looked to you? So if your nipples usually placed front and forward, absolutely fine. If you look tomorrow and they're slightly askew or they've changed position, that's a change that needs checking out. What I'd want you to do then is with your hands, put your hands behind your head and press your hands together. And the reason that I'm asking you to do that is because it innervates certain ligaments within the breast that can change the breast contour. And what that can do then is highlight any changes, whether it be skin texture, whether it be dimpling, whether it be little dips in the skin or lumps in the skin. So remember, arms up and press, and then arms upon your hips and pressing again. And again, it's just changing that contour of the breast so you can visually see any changes. What we're then going to do is we're going to have a feel of our boobs. So 3 fingers, use the pads of 3 fingers, start at your nipple and go behind the nipple in a bit of a circular motion. Work your way around behind the nipple and then work your way circularly around the full breast. Make sure you cover the full breast, and we've got a section of breast tissue that just comes up in front of the shoulder, so make sure you're pressing there as well and testing it. And once you get to the top, just slide the hand underneath your armpit to check for any lumps or bumps in your armpit as well. And that's a breast exam. So obviously then you want to be going across to your other side to be checking your other side, make sure that that's all okay too. If you notice any lumps, bumps, changes that you hadn't noticed before, then it's important that you nip and see your clinician so that they can just do that check for you. Okay. Quite often you can have lumpy boobs for nothing sinister, but it is something that needs checking. And obviously, definitely go for your mammograms. That's really important that you go for those. Bowel screening and your smear tests as well. Remember to keep those up because they're really important. So we've gone through a lot of the signs and the symptoms and things like that. Let's have a little bit of chat about some of the medications that we use. So HRT. Now, HRT has had a bit of bad press within sort of like the last 10 to 15 years. And that bad press meant that a lot of GPs have shied away from prescribing HRT. And the reason for that is there was a study done by the Women's Health Institute, and what the study found, what its findings said, was that HRT increased your risk of breast cancer. And that's the headline that the newspapers went with, that HRT would increase your risk of breast cancer. Therefore, there was many clinicians that wouldn't prescribe it. Now, when they actually looked at the study, the participants that had been recruited into that study, what we found was that they were older ladies. Your risk of breast cancer naturally rises as you get older. So there were older ladies. Some had already had breast cancer. Some had a long family history of breast cancer. So actually the participants didn't map with the findings of breast cancer. So as a medical profession, they said, no, actually, that's not what the findings are showing us, and that it is safe to use HRT. And what we know is that if we imagine that there's 1,000 of us in the room, normal, fit, healthy ladies, out of that 1,000, 23 of us will get breast cancer. If we had that same 1,000 ladies, fit, healthy ladies, all in that room, 27 of, and we placed those ladies on HRT, 27 of us would get breast cancer. So that's 4 more than the normal, fit, healthy. So as a risk analysis, that's quite low. But it's the next 2 that I find more interesting. Out of that 1,000 ladies, if you have 2 units of alcohol a day or more, and imagine that nighttime glass of wine or gin and tonic, it's definitely not a small unit, it's usually a home measure. But if you have 2 units or more, 28 out of every 1,000 of us will get breast cancer. So increased alcohol is more dangerous than HRT. If we've got more jiggle in our wiggle, so if we are overweight or obese, 47 out of every 1,000 will get breast cancer. So our risk of breast cancer is far higher with those lifestyle changes that we need to do. So HRT is good. It does do the job. It restores that hormone function. And what we've got to remember is estrogen is a hormone. So if you had somebody with a low thyroid and they needed thyroid medication to restore their depletion, we would give it and not think. If you had somebody with an insulin, which is a hormone deficiency, so insulin's a hormone, type 1 diabetics, we would give the insulin. So I appreciate that the analogy can be pulled to pieces a little bit, but it's exactly the same with HRT. What we're doing is we're restoring a hormone that the body has had depleted. So it isn't the horror that we think it is. It can give a lot of ladies a really good quality of life. If you take it by tablet format, whilst the risk is low, it is the highest risk. But actually, if you use it as a tablet, a patch, a gel, a spray, a pessary, that dramatically reduces that low risk even lower. So it's the way that it's delivered as well that can make the difference. So let's have a look and a chat about what the alternatives to HRT. So we've already alluded to the fact that we know that certain antidepressant drugs work really well with our hot flushers. So when we look at antidepressant drugs, they're not only there to treat mood, they can definitely help with hot flushes and night sweats. So if your primary symptoms are these hot flushes and night sweats, and you've got this volatility of effect, this mood that's up and down, they may be a really good option for you. So if you go to your GP and they want to prescribe something like that, have a conversation with them. Are you giving me these to help my mood, or are you giving them to help my night sweats? Is there another medication that would help? Have those questions ready. An antihypertensive called clonidine, again, really good at helping night sweats and hot flushes. And again, both of these have no hormone in them. So for ladies who would naturally struggle with hormones, these can be really effective courses of treatment. And then we've got us over-the-counter type things. So these are your complementary and alternative medicines. So a lot of ladies will say, well, I use oil of evening primrose, black cohosh, red clover, St John's wort, all of those, and they work fab for me. And I would say, absolutely brilliant. If they work for you and you're taking it, knowing what you're doing, phenomenal. I'm so pleased it's a positive thing for you. What I would say is that all of those types of herbalist things, please do not just buy them over the counter at the supermarket. In the first instance, make sure you go see a herbalist, because they can definitely affect any of the medications that you're on, so any of the drugs that you're on, and they can sometimes affect certain medical conditions. So please make sure that both your GP knows that you're taking them and that you've had them reviewed by a verified herbalist as well. The other thing to think about with them is they are not a quick fix. Sometimes they can take a good 3 months to get into the system and can make a difference there. So you've got to give it a real good trial of treatment. Now, your soy isoflavins are these phytoestrogens that can help, and these are foods and products that are naturally high in estrogenic properties, so things like oats, etc., those kinds of things. There is a small evidence base that they can be helpful, but it's not conclusive, and again, it's very much independent upon that person. So if you can, you know what I mean, look at a phytoestrogen type diet, and if you Google it, there's lots of things out there, you know what I mean, soya milks, oats, all these types of foods that can help to support the natural estrogenic component. They may help you as well, so it might be worth considering those. So we're nearly there, ladies and gents. So management wise, we've discussed what happens below our belt from our sex lives point of view, our vaginal symptoms, our libido, etc. We've done as physical health. We've gone through bone, cardiovascular, brain, all those kind of things. We've chatted about our personal tropical moments, our vasomotor symptoms, and how we can manage those. Skin, hair and nails we've not really covered, but definitely there can be some changes, and a lot of those can be managed through lifestyle. Lots of moisturisers, definitely. Don't put too many products on the hair. Make sure that your diet is really supporting it from a vitamin and mineral point of view. Brain, mood and lethargy. Yeah, definitely. We know why it happens, and it's about managing that lifestyle and, if needed, some pharmacological help, so some medication. And we've gone through HRT as well as to ways within which we can help and manage that. And that's it. I'm going to take a quick breather with a drink of tea, but let's have a look at some of the questions